Good evening, everyone. We welcome you all to OrthoTv original webinar series. This webinar is brought to us by the unrestricted educational grant from Dr. Reddy's Laboratories, the makers of Ultra Nice, Nice Gel and Omis. Today, we have my very good friend, Dr. Pradeep Moonot, who's a UK trained foot and ankle surgeon. He is AOFAS committee member. He is also the joint secretary of the Indian Foot and Ankle Society. He has his own clinic in Mumbai, and he also visits many centers in Hyderabad and Surat. So over to you, Pradeep.
Thank you, Neeraj, and thank you to the whole OrthoTv team to give me this platform where I could spread knowledge. And I think you guys are doing a wonderful job, and keep it up, I would say. And I'm sure in the last 2 months, I think you probably have not slept and you've been working tirelessly. So again, thank you so much and wish you luck. So today I'll be talking on the management principles of acute LisFranc injuries. Now the key is, as I said, it's an acute LisFranc. We're not going to touch on chronic or long-standing or neglected LisFranc injuries. The talk I've divided into cases, a little bit of relevant anatomy to the surgeons, examination, radiographs, the surgical principles needed to treat these conditions in an effective and appropriate manner, and then we'll just conclude. So let's start with few cases. This is a 30-year-old female who had a minor fall from stairs, and she was diagnosed with a midfoot sprain. She was seen in South India while she was on a holiday, and she was said that she has a midfoot sprain, and she was put in a back slab and sent back. She came back home in Mumbai. She was seen by another physician, a senior orthopedic surgeon, and she was said that she probably had a fracture of the base of the 5th metatarsal. She was in a boot for 6 weeks, and then she was advised to mobilize. She finally came to me 3 months down the line with this kind of deformity, and she said, "Doc, this doesn't seem right. I have this bulge which is coming out. I have also the heel which is going out, and I'm developing probably like a flat foot, and it's hurting." So look at this X-ray. We clearly can make out that there is something going on here. There is definitely a widening between the medial and the middle cuneiform, and also here you can see, what we English people would probably call it, you can drive a bus through that gap. That's what it was, like a bunny seat. So this was a Miss LisFranc. Another interesting story, she's a 23-year-old orthopedic nurse who was in a OT when I was working in a previous hospital, had a twisting injury to her foot, was seen in A&E, and she was diagnosed as sprain by the A&E doctors and put in a back slab. A few days later, she was seen by my registrar, and she said it was diagnosed with a sprain, put in a back slab, and said, "Go away, you'll be fine." She came back a week to 10 days later saying, "Doc, this pain is not settling down. The swelling is still there, and it doesn't seem right." That's the thing she mentioned. And clearly, the first thing, if you see, this is a non-weight bearing X-ray. I advise for a weight bearing X-ray. Clearly, you can see again the telltale signs. There is clearly a subluxation of the second TMD joint. And here you can clearly see the flake sign or a piece of bone in the first TMD joint, in the first web space, which is pathognomic of a LisFranc injury. So I advised her a CT scan, which confirmed the diagnosis, and she was appropriately treated. So these two cases makes you think, why did we miss the LisFranc injury? Why is it so common? And the second part to answer is, why does LisFranc joints are so important that these LisFranc injuries should not be missed? And we will touch base on how to treat them. Do you treat them conservatively, fix them, or fuse them? So first question, why was LisFranc injury missed? We know the fact that 20 to 40% of patients with LisFranc injuries are not treated in a timely manner. And I'm not saying that, the literature says that. And these usually are overlooked or undiagnosed or misdiagnosed as foot sprains, or sometimes you have an isolated fracture of the tarsal and metatarsal where your eyes clearly see them, recognizes them, and treats them and miss the LisFranc. These are sometimes involved in a high energy injuries, and their patients have multiple trauma, And it's very easy the foot to be the last part to be looked at, and these injuries can be missed. And also we know the fact in developing nation, these could be missed because of lack of awareness, or just the surgeon or the clinician or the physician does not know about the existence of these injuries. And the last but not the least part, we have lots of patients, even in India, who does not seek medical care or they come very late. Now, why do we need to know about LisFranc? That was the second point we were talking about. Because miss LisFranc leads to chronic pain. It is long-standing, debility or morbidity is there. There's significant functional loss because, as you can see here, a patient develops a midfoot abduction. He develops a residual or a deformity, which is a pes planus or a pes plano valgus, ultimately leading to secondary arthritis, which increases significant morbidity and a loss of pain and loss of function. The incidence of acute LisFranc is quite low. It's 0.1 to 0.9 percent of all fractures. Because the incidence is low, that's why these can be easily missed. I've already said 20 to 40% are easily missed. And in UK, when I was there was a paper done which shows that this is one of the commonest injuries for litigation by the patient, especially on either the general practitioner or the A&E staff. They are usually picked up well by the orthopedic surgeons. Anatomy, I won't bore you into the anatomy, but the key thing to remember, the 4 major units. Now, if you read different textbooks, they can divide into 3 units or 4 units. I like to do 4 units because the first unit is the first metatarsal and medial cuneiform, and it is not fixed. There is a 6 degrees of mobility, which is important. The second metatarsal middle cuneiform is the second unit. The third metatarsal and the lateral cuneiform is the third unit. Now, these are firmly fixed. There is no movement at all. And the last unit is the mobile unit of the midfoot, which is the 4th and the 5th metatarsal to the cuboid. And that's where the mobility happens in the midfoot. LisFranc ligament, it's a large oblique ligament coming from the base of the plantar aspect of the second metatarsal to the medial cuneiform on the base side. And here you can see there's a next diagram. There are 3 different ligaments which are present: the dorsal, the interosseous, and the plantar. Okay, the dorsal, the interosseous is quite a thick ligament. Then you have the plantar, and then you have the dorsal part. If you look at the anatomical sections, this is the anatomy which shows a nice LisFranc ligament. Now, I don't want you to know about the anatomy, but the key thing to remember is when you get an MRI done, especially in the pure ligamentous, I would advise you to look at the MRI scans, because clearly if the sections are done right, you can clearly see the LisFranc ligament on the MRI sections. And if you speak to your radiologist and tell them that you're suspecting a LisFranc injury, they'll be able to help you in the diagnosis. Biomechanical studies by my friend Matt Solan has concluded that LisFranc ligament was strongest to give the stability in the LisFranc joint, followed by the plantar ligaments and the dorsal ligaments. And structural stability to the transverse arch is enhanced by both the plantar muscles and the other muscles like the peroneus longus, tibialis anterior, and tibialis posterior. Now we finished with the anatomy. What we would want to know is how is the mechanism of injury. There's 2 types of injury: the direct injury and the indirect injury. 2 different plantar flexion mechanisms lead to a dorsal subluxation. Here it is, where especially when Jacques the LisFranc described it, where he was coming off the horse and the foot gets stuck in the saddle and the body rolls over it. There is a dorsiflexion type of a force happening where the ankle is equinus, and you have a subluxation or a dislocation of the LisFranc joint. What it is called is a joint is rolled over by the body. So the whole body weight comes on to the midfoot and the forefoot area. These are the other kind of injuries. So we do not see any more of the horses type of injury, but the commonest in my practice and in our day-to-day practice is where patients miss a step and the body rolls over and they get a LisFranc injury. That's a commonest type. You can have it in contact sports as well, or you could see in a road traffic accident. These are the direct type of injuries. The indirect type of injuries, where there is a twisting injuries and there is a fracture of the base of the first and the second metatarsal, but along with it, you can have a fracture of the cuboid. So the whole foot is getting twisted, And this, you can have a combination of this type of injury, you can see is it called as a nutcracker injury. So there's a significant midfoot type of injuries. Burroughs et al. In 1998, they classified sprains in the midfoot, that is a second TMD joint, and graded them as grade 1, 2, and 3. Where grade 1, there is pain at the joint, there is minimal swelling, and there is no instability of the joint. So there is, if you do a clinical examination and you palpate on the second TMD, there is mild pain and swelling. That's it, no instability. Second, the grade 2, increased pain and swelling of the joint with mild laxity but no instability. But the key thing to remember is to identify the grade 3 types of injury where there is complete disruption of the LisFranc ligament and there is instability. The instability, when we talk about, there is a significant diastasis and the first web space is more than 2 to 5 millimeter. And if you do a weight bearing X-ray, you can see a dorsal subluxation as well. And if you do a weight bearing again, you can see a loss of arch as well. And these patients definitely need to get something. A physical examination is important. And the key thing is any midfoot injuries or patient complaining of significant swelling and pain, you have to have a very high index of suspicion. And I would say in my books, if a patient has some midfoot pain and swelling after trauma, he has a LisFranc injury unless proven otherwise. They have a swelling around in the midfoot area, and they could be a combination or a part of the patients with polytrauma. And the key thing with these patients is you assess the vascular status by checking for pulse dorsalis pedis, posterior tibal, and check for the microcirculation, a capillary refill in all the toes. And assess the soft tissue, especially in open fractures or there is significant degloving injuries. Remember that even in open fractures, you could have a compartment syndrome and always check for that. Now, this is a patient of mine. Here you can clearly see how this patient had a swelling in this midfoot area. Forefoot was fine, hindfoot and ankle was fine. So this is almost like a pathognomic of a LisFranc injury, a swelling and large lump in the midfoot area. And even initially, they will complain of unable to weight bear. But even if you put them in a back slab, you call them after a week or 10 days, and they would still not be able to weight bear, you should have a high index of suspicion. You palpate them, and what I do is when I do my palpation, I start from the normal, so from the toe, and then gradually go up like this. And if you have tenderness present at the base of the second metatarsal and the TMD joint, that confirms my diagnosis that a patient may have a LisFranc injury. The other test to do is you hold the foot with one hand, stabilize the hind foot with the other hand, and you try to do a little bit of rotation. There will be a rotation in the midfoot area, and if the patient complains of pain, again, alarm bell should be ringing in your mind. Don't forget to look at the plantar aspect of the foot, because if you see something like this, where there is a clear plantar ecchymosis present, that's again a telltale sign or a pathognomic sign of a LisFranc injury. As I said, gentle stressing, or if you take the second metatarsal and you hold it in your hand, and if you do dorsiflexion, plantarflexion, and rotation, if they complain of pain, that's again a pathognomic sign, and this is called as a piano key sign. Once you are done with that, next thing is radiographic evaluation, where you do the key thing in getting your x-rays as you get an AP and a lateral and a 30-degree oblique views. And these are almost mandatory. Now, what do you look for in your radiographs? In the AP view, these are the lines which you should be seeing it day in, day out in your normal x-ray. So when you have an unfamiliar or an injury patient with LisFranc or a subtle LisFranc, your eyes will be able to pick up immediately. So in an AP view, the lateral border of the first metatarsal is aligned with the lateral border of the medial cuneiform. On an AP view again, the medial border of the second metatarsal is aligned with the medial border of the intermediate cuneiform, like this. On an oblique view, the medial border and the lateral borders of the lateral cuneiform is aligned with the medial and lateral borders of the third metatarsal. Again, in an oblique view, the medial border of the cuboid should be aligned with the medial border of the fourth metatarsal. There's another sign which we call it, which we do not do it, but it's the similar thing like you would do in an ankle fracture, similar where you can see this nice curvature should be there. Again, like a small coin sign or a dime sign, and this should be also be continuous. So if you have a disruption involving the fifth, then you can say that there is a LisFranc injury. Another thing, which is a new thing, which is called as a north sign, where in a very subtle LisFranc, you do a weight-bearing X-rays, and if you see a notch on the medial cuneiform, that means the medial cuneiform is rotated, and that also signifies a LisFranc injury. And this could be in isolation without the CM-M2 widening. So there may not be widening at the first web space, but there could be a north sign. So this is again a sign for a very subtle LisFranc. On a lateral view, the dorsal surface of the first and the second metatarsal should be level with the corresponding cuneiform. And if there is a subluxation, here you can clearly see there is a dorsal subluxation suggestive of LisFranc. Now, all these signs, all these radiographs which you're looking at are not there to diagnose these obvious fractures, but these are signs and lines which you need to know, especially to pick up subtle LisFranc and treat them appropriately so you do not miss them. If your X-rays are normal and you're still suspecting a high index of suspicion of LisFranc, the next thing which you could do is you can get the weight-bearing X-rays, both AP and lateral, which effectively provides a stress and may demonstrate a subtle diastasis. As I showed in one of the X-rays of the nurses, you see this is non-weight-bearing X-ray and a weight-bearing X-ray, and you can clearly see this line of the second TMT joint is broken. Even if you cannot get a weight-bearing X-rays and you're suspicious of a LisFranc, what additional imaging you can do? So you can take them to theater and do stress views or fluoroscopy and check if there is instability at the TMT joints, or you could do a CT scan, which shows a subluxation, a mild subluxation, or an MRI scan, which may show a LisFranc ligament injury plus minus the subluxation. If you're highly suspicious, as I've done in the 2 cases, you can send the patient back, call them back in 7 to 10 days and repeat the X-rays and keep looking till you're satisfied that there is no LisFranc injury. Once you're diagnosed with a LisFranc, and the key thing that comes to the management is a conservative or a surgical, and that's always a dilemma. And these dilemma is usually in subtle LisFranc, not in a big obvious LisFranc. The goals of treatment in LisFranc is to make sure that the patient gets a painless, plantigrade, stable foot. To make sure that the maintenance of the, make sure that the anatomic alignment is maintained in the midfoot, because that's a key to maintaining the arch. How do you check for stability? The definition of instability is defined as greater than 2 millimeter shift in a normal ankle, in a normal joint position. So as I said, if there is a diastasis between the base of the second and the first, that means that there's the first web space, I would say. And if that is less than 2.7 millimeter, that joint is probably stable. But if it is more than 2.7, that is unstable, and that requires operative management. In my books, if you see a displacement, which you can see from your naked eye, I would suggest operative fixation. If really in all your imaging, you can prove that there is no displacement or less than 2 millimeter displacement of the TMT joint with no dorsal subluxation, then you could manage these patients non-operatively. And non-operative management means not just putting them in a plaster and sending them away. You put them in a plaster, you call them back in a week, 10 days, you again take weight-bearing X-rays and stress views and make sure there is no subluxation or no displacement. And if you're sure, then you can continue non-weight bearing for 6 weeks and then protected weight bearing for another 4 to 6 weeks. If there is instability present in the TMT joints or in the LisFranc joint, then the best result is anatomical reduction and stable fixation. And a lot of times people keep asking me, when is the best time of surgery? Surgery can be done as soon as the swelling is down, so your wound does not heal or there is no wound complication. And these patients can be easily managed within the first 2 weeks. I have managed these patients with open reduction and fixation, even up to 6 weeks, but usually 2 weeks is the norm. Now, if you have open fractures, or if there is a vascular compromise or a compartment syndrome, these patients are surgical emergencies and you need to take them immediately and treat them. And especially patients who have open fractures, or if you have done a fasciotomy, then the immediate or the first thing probably is you can stabilize these LisFranc joints by K-wires. Once the wound closes or heals, then you can start thinking, and there is no infection, then you can start thinking of a permanent management or a permanent fixation with plates and screws. But in my practice, the only role for KYs is in these kind of emergencies. Rest, in all the patients, I would do an internal open reduction and internal fixation. You need to know your anatomy quite well. You need to know the Tom, Dick, and Harry and the neurovascular bundle, because this is where you're going to operate. And this is your EHL and your neurovascular bundle. The dorsal incision should be centered over the involved joints, because you can have a 1, 2, 3 or 1, 2, 3, 4, 5, all the TMD joints involved, and you need to plan it properly so there is enough skin bridge between your two incisions. What I do is, in all my patients, in spite of, I'm sure, which joints I'm going to be fixing, I always again do fluoroscopy on table to check which joints I would need to fix. Because if I'm fixing the first 3 medial joints, then my medial incision will be on the medial side to fix the first EMT, and the second incision will be between the second and third to fix the second and third. And there is enough skin bridge of around 7 centimeter between these two skin incisions. Now, if your fixation is only of the first and the second TMT joint, then my incision is centered in the first web space, or between the first and the second metatarsals, and it is lateral to the EHL. I identify the neurovascular bundle, and retract it, and then approach the TMT joint. Once I have done that, once I've retracted, I expose the TMT joint, I clear that up. Once I've done that, I use a large towel clip or a holding forceps or a prongs, reduce the joint. Once I'm happy with the reduction, then I pass a guide wire for your 4 millimeter guide wire to fix it from the base of the second metatarsal into the medial cuneiform. Now, this is slightly different and a newer concept. In the past, people used to put a wire from the medial cuneiform to the base of the second. It's like going from a larger bone to a smaller bone, which you can have a high chance of missing the second or smaller bone. While if you go from the base of the second into the medial cuneiform, it's much easier to do that. Once you have done that, you check under your C-arm, you make sure the reduction is well maintained. Once you have done that, you check if you need to reduce the other joints as well, like the second, third, or fourth, and you can plan your incisions. Once you are happy with the reduction, then you would want to start doing your permanent fixation. The key thing is, the first thing is the LisFranc screw, or the home run screw, I would say, in your midfoot region. The LisFranc screw goes from the base of the second into the medial cuneiform. Here you can see it's a fully threaded screw. It's a positional screw. It is not a compression screw. You already got a compression or a reduction from your towel clip. This is a positional screw. And you need to use a fully threaded screw, not a cannulated screw, because a fully threaded screw have a better strength and less chances of breakage compared to the cannulated screw. That's why you need a fully threaded solid screws. Once you have done that, you can proceed with your permanent fixation. Say, this is the way I've mentioned the LisFranc screw grows. Once that's been done, you can put your plates. If after you put your LisFranc screw, you still find that the intercuneiform space is open up, you can use your intercuneiform screw as well. After that, you can, if you're fixing your medial column, then you fix it with either plate or 2 screws. If you see in all of my patients, another thing which I want to point out is these screws, these are extra articular screws, and I'll show you this in this diagram. These are extra articular screws. So it goes from the base of the second, it goes outside and it goes into the cuneiform. It is not going through your second TMT joint or the first TMT joint. And even in this example, it is going extra articular. And if you see in all my x-rays, These are extra-articular screws. I do not like to put intra-articular screws. Even if you use your plate, these plates are joint spanning, but they're joint stabilized. So your joint surface is not damaged. People in the past used to pass screws across the joint, across this way and across this way, but that would damage the cartilage a lot. So one screw probably damages around 30% of the cartilage. So if you're passing two screws, your 60% joint is damaged. And that's why LisFranc, even LisFranc joints, even after fixation, had almost 100% arthritic rate. If you're having a fourth and the fifth TMT joint which you open to use, these should be fixed with K wires and not by screws, because these are mobile joints and the K wires need to come out in around 5 to 6 weeks time. Now, open reduction and internal fixation remains the traditional treatment. If, however, if there is a pure ligamentous injuries, now it is proven that even in non-athletes and athlete patients, primary arthrodesis gives a better result than an open reduction internal fixation. So that's one more food for thought. And I think and nowadays we do more and more arthrodesis and purely ligamentous injuries. Now I'll go through some cases. 34-year-old female involved in RTA, treated with a plaster. 2 months later, comes back with increasing pain in the second TMT joint around the LisFranc area. You can see here now weight-bearing X-rays. You can see there is a flake of bone here. There is a subluxation and a break in the line of the medial border of the metatarsal and the middle cuneiform. I got a weight-bearing CT scan. I had the privilege and the access to the weight-bearing CT scans in Mumbai, and it can clearly show there is a whiting of the CMM2 with a measurement of around 5 to 6 millimeters. So she had a open reduction. You can clearly see the periosteum elevator is going right into the intercuneiform in the TMT joint. This was fixed with so initially reduced with a ball tip prong, then a guide wire is put, and that's your final image. So that's a long threaded, a non-cannulated, fully threaded screw and a plate to stabilize it. This was done 6 months later or 8 months later. I think the plate was removed, and that's 1 year down the line. Arch is well maintained, no subluxation, no instability seen. She did very well. Another case, again, injury here, you can clearly see whitening at the intercuneiform area, fixed with a screw and a plate, did very well. This is an interesting case. This is a middle-aged chap, had a twisting injury to the foot, was seen by multiple surgeons, complaining of pain. When I saw this X-ray, he came there with this X-ray, I thought, hang on, he has a clear LisFranc injury. Excuse me. He had a clear LisFranc injury. So when I examined him again, he had no tenderness, no piano sign was negative, nothing. But he had tenderness on the medial side of the first TMT joint. And that was quite odd. I thought this was LisFranc, but or a LisFranc variant. So again, I got a weight-bearing CT scan done, and here you can clearly see the first TMT joint is unstable. I got finally agreed for surgery, and look at this. When I did a screening, see how unstable this is. The first TMT joint, look at that. And this is the intra-op image. I can clearly put my periosteum elevator in the LisFranc between the first and the second. And see how unstable it is when I do the ballotment. I'll run that again. And here you can clearly see that's the step was the tip of the artery forceps. Finally, he had a surgical fixation done with a T-plate, and this is after the fixation, the whole foot is moving as one, and the TMT joint is quite stable. I'll run that again, and he did very well. And that's the follow-up X-rays. So my algorithm for management of acute LisFranc injuries, you can divide these patients into, is the LisFranc injury stable or unstable? If you think that the LisFranc injury is stable, check for plantar ecchymosis. If there is plantar ecchymosis, as I said, get weight-bearing X-rays or stress X-rays. And in spite of you doing all investigation, if you find that there is no instability, then you can continue with your non-weight-bearing or a conservative treatment. But I find most of these patients after here, even if you have a subtle LisFranc, they have a subluxation or a displacement of more than 2 to 3 millimeter, which ultimately goes in the category of instability or unstable subluxation, which requires an open reduction and internal fixation. If they are purely ligamentous, yes, you can try for a LisFranc arthrodesis. That's your TMT joint arthrodesis as well. So in my book, there is no role of K-wire fixations or conservative treatment for unstable LisFranc injuries. Now, a lot of people ask me, how do you fix them? You have special plates for midfoot by various companies which are available even in India now. You have special T plates, 2-hole plates. You have these X plates, which you, through single incision, you can stabilize the first and the second joint. So no need to worry, and you need to roam around for special dental plates or other things. Post-operatively, I put them in a baxilla for around 14 days till the sutures come out. Then put them in a cast for non-weight bearing for total 6 weeks. Then remove them and probably give them a walker boot or a cast and gradually increase weight bearing for another 6 weeks. I give them a arch support for at least up to 6 months period. Now, the second thing is a lot of people come asking is, when do you ask the hardware removal? Now, the lateral column, as I said, is a mobile unit. So these K-wires can be removed at around 6 weeks mark. But the medial side, the first, second, and third ray, the implant should not be removed at least before 6 months. And the reason behind that is it takes all the ligaments, especially the LisFranc ligament, to heal. It takes almost 6 months to heal, and that's why your implant should not come out. And that's one of the reasons why K-wires are not recommended for these. You can have foot compartment syndrome or infections and wound complications. My late complications, as I said, is post-traumatic arthritis, which is present in most cases but not be symptomatic. But nowadays, since we use less and less of intra-articular screws, this incidence will probably go down. And the reason for that, again, is because either the initial injury where the chondral damage is there, or if you're treating through transarticular screws, then the cartilage will be damaged. If they're symptomatic and if you're finished with your conservative, then they may need a fusion. Excellent results with anatomic alignment are seen in LisFranc injury almost up to 95% of the time. While if you have a missed LisFranc, then only 1/3 of these patients do well. And that is one of the reasons why LisFranc injuries should not be missed and should be treated appropriately in a timely manner. And if you have a missed LisFranc or treating missed LisFranc, it takes a long rehabilitation program. And as I've already mentioned, if you have a missed LisFranc, then they do have a lot of chronic pain, instability, and deformities. So in conclusion, LisFranc injuries are very commonly missed injuries. They are rare injuries, but they are commonly missed. And that's why any patient coming with a midfoot sprain, you should have a high index of suspicion. And you should investigate thoroughly to make sure to rule out a LisFranc injury. If their unstable anatomic reduction is the key to get a very good fixation with either plates or screws or both, there's no role of K-wire except in open fractures or if there is a compartment syndrome. And if they are missed, then they have high morbidity, especially because they cause a lot of deformities. And what better person than Jacques LisFranc, they Saint Martin, to say this: surgery is bright when operating, but it is still brighter when there is no blood and mutilation and yet leads to patient's recovery. And nowhere else I can see this statement aptly adapted than the LisFranc injuries. Thank you very much for listening. Thank you very much, OrthoTv as well.
Yes, thank you, Pradeep. That was a very good comprehensive coverage of the LisFranc fracture dislocations. So I have a few questions. I would like to start with investigations. The whole issue in our country, or at least in many small setups, are taking the weight bearing X-ray. Or same issue happens with me, the stress view X-ray of the ankle for the lateral malleolus when you are planning to conserve. So
Correct.
how do you describe that to take the weight bearing X-ray? I don't think I saw that slide. That's why I'm asking you this question, I think.
So I haven't specifically put a weight bearing X-ray, but what my point is, do not, if in your clinical examination, if we are sure that there is a LisFranc and your X-ray appears normal in the first time, you can send them back in a back slab, call them in 7 days time, where the pain may settle down. You will probably give them good analgesics, and then you can ask them to stand. Now, you may not be able to do a full single leg weight bearing X-ray, but even if you can ask the patient to put a lot of pressure even on your bucket table and get an X-ray, that should be good enough. Even if whatever you attempted weight bearing. So in my clinic, I have a 100 mm machine and I have a weight bearing stool. Now, sometimes these patients, especially elderly patients, may not be able to do it or not able to stand, then tough luck, you can't keep them pressing and causing them pain. If you cannot get your weight bearing after attempted, then you have two choices. Either if you have your own setup, then you can do it is you can take them in a OT, do your stress views and confirm the diagnosis. But in Bombay, it's not possible. The cost is too much to take a patient to theater. Then I would send them for an MRI stroke a CT scan. So that's what I would do it.
Okay.
We had the access to a weight bearing CT in Mumbai for almost 9 months or so, but that's gone now. We don't have any weight bearing CT scans now.
Okay. So after the investigation, we'll come to a little bit of the CT and MRI part. So when we are seeing a bony injury, so for that time, is only CT enough, or you still need an MRI? We see a bony injury.
If it is a bony injury, you can clearly see a subluxation. If your X-rays are fine, I do not need to investigate it any further. If your X-rays are conclusive that there is LisFranc. The problem becomes is if your X-rays are very subtle and especially you can't get a good lateral, then yes, or if there are too many other injuries happening in the foot, then getting a CT would help, because that will show you that there is a subluxation or dorsal displacement. You can clearly see in your sagittal cuts, and that will help you in your treatment. If they're part of a polytrauma, if you have a fracture shaft, metatarsal, and a lot of things going on, and you are contemplating, should I just do K-wires or do I need to do open reduction, then a CT would help. If it is a pure ligamentous injury, there is no bony injury, then I would send it for an MRI.
Okay. And after this now, till how many weeks will you do a fixation versus arthrodesis?
It's quite interesting. That's one of my favorite talk, which I did not do. That's another half an hour, 45 minutes talk. And I've given that even in the advanced foot and ankle, which is a Miss LisFranc. Okay. And I have done even up to 3 months open reduction and internal fixation, and patients have done really well. And I have developed an algorithm as well, and we are about to publish this study as well. But for paper's sake and for literature, 6 weeks is usually the time where you can attempt. Now, again, you have a different degrees of displacement. If their joints are really out for a long period of time, then yes, you will not be able to get those reduction, anatomical reduction after 6 weeks. Then those cases, you're looking at a fusion. But if they're mild, as I showed you in the first case, which she was in Bangalore and then she came to Mumbai, she finally came 3 months down the line. But I could still do an ORIF because there was a subtle displacement. But if it is a significant displacement, especially neglected or patients are really presenting late, in those cases, a fusion is a better option.
And in these subtle patients, this pain, if you left alone, basically if somebody does not operate, so is it just last lifelong, or they learn to live with it, or it eventually will go away?
Interesting. So I have another patient who somebody missed a LisFranc, or actually had a LisFranc but treated it conservatively from Chembur area only. And he's coming to me almost up to 2.5 years. He is managing quite well, but I know the fact he's starting to drop now. So he's starting to develop a little bit of pes planus. So at some point of time, he will need to do something. But till then, if they're not significantly symptomatic, I'm putting them in a customized insoles, limited basically work in the realms of his pain limit. And at some point of time, he will come for a fusion. So he will. But they invariably fall down because that second TMT is the keystone for the arch. We know that.
So now we come to the surgical part. These plates which you showed are, most of them are imported and very costly.
No, so we have one Indian as well. So there is an Indian company who makes it as well.
Yeah, okay. So that Indian company, I have tried to use it. Their service is very bad. In Bombay, at least. I don't know about other cities, but in service is very bad. I wouldn't want to take the name because I'm doing it negatively. But I've tried to tell him to bring the plates and everything. The plates are good, extremely good compared to what Indian should be and the cost effectiveness. But the service is so bad that sometimes they will not have the right size screw. Sometimes they will not have the right size plate on the table. Is it the same experience with you?
Yes.
Because they always quote your name. When these companies always quote your name, because there are only 2 foot and ankle surgeons in Bombay and you are the senior one.
So it's interesting, and I have had the same issues where literally I have had thrown instruments on them. There are 2 parts to it. Because it's an Indian company, it's a catch-22. They do not want to invest too much because they do not see that much business. And because they do not invest, then you have shitty instruments. The instruments is a problem, not the implants. Actually, implants is an issue, but that's not too much. But instrumentation is an issue. So I've had patients where my screwdriver has broken into the screw. And luckily, screwdriver, the tip has broken into the screw, and luckily it had just locked enough that I did not have to do anything. So I've had instances of that as well. But yes, they give you a 3.5 plate and they get a 2.7 screw, or vice versa. So they have a 2.7 plate and a 3.5, and then hang on, how do you operate? How do you put a 3.5 screw in a 2.7 plate? You can't do that. Yes, service is an issue, but till somebody comes, an Indian company comes in the market, we are at the realms of these people, I would say.
Have you used the Synthesis ones, or Synthesis ones, are they available in India?
Yes, they are available. And again, there is only 2 sets in India, 1 or 2 sets, I think. So the whole Mumbai and the whole West is covered by South as well. So this is always going to be an issue where, but I think as the numbers go up, the companies will realize that they need more and more sets and the service will improve. So, and with LisFranc, I think more and more people are doing surgery, so that they will have to make the sets available. But Synthesis is good as well, but the size is slightly bigger. They are slightly bulkier.
Okay, and these plates, do they hurt? Because there is hardly any skin in the dorsal area, especially in the medial side. So do they actually start hurting and then you remove the implant, or you were told that till it doesn't give symptoms, sometimes you don't remove the implants only?
Yeah,
especially the medial side.
Yeah, so if you see, these are 2, so you should not use the dental plates. The dental plates are 2 millimeter. Though they're 2 millimeter, they're flimsy. You can literally bend with the hand, so they will not give you stability. So you have to use the foot specified plates. So that's the first part. Second, the reason why you should use the foot plates is because you have locking screws, which are literally flush with the plate, so they do not hurt. If you were using non-locking screws, the head bulges out a little bit, and that is usually a cause of irritation. But per se, if your screws are flush with the plate, they do not hurt.
Okay. And about the post-operative mobilization, you were saying you give them first 15 days for naturally suture removal, a back slab and non-weight bearing. Then again for 4 to 6 weeks, a proper cast. And then some cast boot. What is exactly that? It's like an air cast or something else?
So walker boot. So walker boot, you can use anything, or you can use a cast. So whichever way you want. So you can make weight bear in a plaster cast, or you can give them a walker boot. Removable, you can mobilize it, and when they weight bear, you're weight bearing in the walker boot. The whole concept is it takes time for the whole LisFranc injury to heal, and especially the ligament. So that's why you're slow in mobilization. Don't forget the arch support. I've written 6 months, but my patients 6 months to 1 year, they have a arch support. They will not walk without that insole.
So the insole you give the ready-made one, or you customize it for them?
I customize it. Customize it. The reason is that they've spent so much. Why for that few thousand rupees you want to have that neglect?
Ashok, do you have a question for him from research point of view?
Yeah, so one of my basic area of research is patient outcomes.
Yes,
So
sir.
I would like to know how many of these successful surgeries the patient returned to their previous activity level, or is there
So,
a issue with modification of activity even after the successful surgical outcome?
so if you've seen the examples which I showed you, there were two doctors.
Yeah.
Okay. So one is in Jaslok, another one is a family physician working with a government hospital. Both have gone well. If the Jaslok guy went back to his almost full night duty, he was a urology resident. He's still a urology resident. He's gone back to doing his full duties and everything within 2.5 months. And the other lady whom I showed 1 year later, she had her implants removed. She's back to her self. The other chap with the first EMD, which is a LisFranc variant, everybody's gone back. The lady who had the 3 months later fixed, which was meshed from Bangalore and Mumbai, she is also back to her normal. She is actually now pregnant with a second child.
So
So
nobody had to
everybody's
modify their activities or
no,
modify their occupation as such. So
no.
it doesn't, if the surgery is successful, it means it doesn't impact the quality of life in further quality of life. So that's
Correct.
good.
So the key thing is, as long as you get an anatomical reduction and a stable fixation, you
Right.
will have a and I have not used in my whole last 5 years. I have not used intra-articular screws. I find it one is technically slightly challenging, especially for the first EMT joint, because you have to make a burr hole, you have to get that starting hole very correctly, and then go through that. So I've used plates right from day one, so that probably helps in getting a better outcome, I think. And second, as I said, the patient who have missed, they keep coming back again and again in my OPD every 3 months. Some sort of the other pains, aches and pains. They are not ready for fusion, but they will come in some time now.
Okay. So
So
that's good.
it's interesting because the Miss LisFranc is very dear to me, and I'm looking to publish on that now. I think we have almost like 6-7 cases now for that.
That's great.
Okay. So thank you, Pradeep. Thank you for sparing your time. We have now all started going back to work slowly and steadily. And I see that both of you have gone to full-time work, and I am not. I am still doing half day.
So I'm working alternate day. I'm working alternate day 4 hours, but the 4 hours, trust me, appears like 10 hours. It just makes you very tired.
So we thank Dr. Pradeep to spare his time and to give us a very good comprehensive coverage of the LisFranc fracture dislocation, an injury which is commonly missed, and now we should not miss it after listening to his talk. And we should concentrate on getting a good investigation like X-ray, CT scan, and MRI, and we should have a very low threshold for doing it. And especially a weight, if you are not able to do a weight bearing X-ray, you have your own setup, take him in the OT, do it under C-arm. So that's what I learned today, besides the surgical part and the post-op rehab part. So thank you, Pradeep, and we thank Dr. Reddy's lab for bringing us this webinar. They are the makers of Omis, Nice Gel, and Ultra Nice. Thank you very much, and good night.
Thank